introduction. Welcome, everybody. This is Donna Jacobson. It's my real pleasure to welcome everybody to this webinar. As Jose just mentioned, and you all know, given the current events, we have had to postpone our New York and Atlanta courses, and we wanted to try to do something that at least get some information to the audiences, the registered audience for those courses. I see a lot of familiar names in the participants who are joining the webinar, and I'm so happy that you're able to do this. By way of just a quick agenda, what we're going to do this afternoon is to first start with an update on the cure research that was presented at CROI 2020, this past virtual meeting by Joe Eron. Then we're going to hear from Mike Saag with his personal experience with COVID-19. And then we're going to close up with Joe is going to give us a really comprehensive review of the antiretroviral therapy and strategies data that were presented at Virtual CROI 2020. At the end, as usual, for those who have participated before, we'll have a Q&A session where you'll be able to ask questions of any of the participants here on the website. So just reviewing, as you all know, just last week we realized, of course, that we had to postpone the New York course. And we originally told everybody we would have a webinar on that day, on the 19th, the day of the course. But since we had to postpone Atlanta at the same time, we figured we would postpone the March 19th webinar until today. So we're also very glad we did, because we realized how much time, especially Dr. Eron needed, and for you all needed to get your schedules together for this. Just a little bit of a reminder, on March 6th, which was the Friday before CROI, we had just that evening started hearing more about the Biogen meeting in Boston and a little bit more about the impact on individuals beyond what had already been released to the press and was expected to be released to the press on the next day. And that's when we called CROI 2020 a virtual meeting. Basically, we had a contingent of 15 of the CROI Program Committee and IAS-USA board members helping to introduce the different virtual sessions and to pull together all of the talks that were presented on the website. Joe Eron and Mike Saag both being part of what we now call the Virtual CROI 2020 Dream Team, along with 8 IAS-USA staff and about 30 technicians who really pulled off this remarkable thing with 2 days' notice. But we were only beginning to see what the overall impact of COVID-19 was going to have on us worldwide. Here's an update of the terrible statistics of this disease. And this is as of today, and we see that the U.S. is gaining quickly to get on the top of the list, and we are grateful for everyone who's working on the front lines of this. So for those of you who registered for New York and Atlanta, we really thank you for your patience in all of this unfolding. We will reschedule and we'll automatically transfer your registration. However, if you wish to have your registration fee refunded, just let us know and understand it's going to take us a couple of weeks. We're all here sheltered at place and in place until we can get back to the office, but we will be issuing refunds. Until now, until we're able to do that, we do hope that this webinar will provide you with at least some information that we weren't able to provide at either of the courses. And because this has been pulled together pretty quickly, we are going to thank you in advance for your patience with any glitches that we have at this point. So what I would like to do now is introduce everyone who's participating. Jerry Friedland and Paul Volberding from the New York course chairs. Jeff Lennox and Mike Saag were the Atlanta course chairs, and our speakers, Joe Eron and Mike Saag. So I'd like to turn it over now to Dr. Friedland and Dr. Volberding to continue the discussions.
Thanks so much, Donna, and welcome to the audience. Jerry and I are really pleased to be able to help bring this information to you. And I'll start and go through some of the structures of the course, how you're going to ask questions and issues like that. Thank various people. I'll then give the chair's position over to Jerry, who will also extend his thanks and introduce Joe Eron. So here are the learning objectives. As Donna said, we're going to talk about the cure research presented at CROI, hear from Mike Saag about his infection with this coronavirus, and then try to dive into some of the many findings at CROI about the management of patients. So the International Antiviral Society USA, IAS-USA, is accredited by ACCME for physicians, and they designate this for a maximum of 1.5 credits, and we'll talk about claiming those credits in a bit. And we, as always, welcome the active participation of our nursing and pharmacy colleagues, and credits for both nursing and pharmacy are shown on this slide. We couldn't do what we do without the support of a variety of supporters, and you see them listed here. We do everything possible to make sure that we have a very high firewall between the supporters and the content of the program. The supporters have been very good with that. The funds that are offered to support the IAS-USA are pooled, and there is no connection, again, with any specific company and any specific content. So we thank the top supporters, Gilead, Merck, and ViiV, and also Janssen. And we also, as we are required to do by ACCME, the people from those organizations are welcome to listen to the proceedings, but won't be participating in the Q&A. So a lot of you have done webinars before. Probably a lot of you have done IAS-USA webinars before, but let's talk about how you participate with this. We will be asking questions. I'm going to be asking some demographic questions in just a bit. And then you will see a separate window. We'll show you the questions, and choose your response from the poll, not in the chat function, and you'll see that as we go forward. And to ask questions to a speaker, and especially you can do that throughout the program. We'll have a Q&A at the very end, and we'll have staff that are going to be going through all the questions and trying to group them to make it go as efficiently as possible. It's good to ask questions to specific speakers if you can. That way, Jerry and I can help take turns directing the questions to those speakers. So you'll answer the poll questions, and we'll start with one right away. For which course, assuming you were registered for one of these courses, were you registered? A, New York, and B, Atlanta, or you don't choose to vote. So let's see how this goes. I'm seeing responses come in, and I think we've got pretty much 2/3 of all people voting. Maybe that's what we're going to see. So the the responses then show that about 44% of the people signed up for New York, and about 56% showed for Atlanta. Let's go on to the next slide. Number 2, have you watched any of the virtual CROI 2020 webcasts when the meeting was going on? This is simple, yes or no, A or B. So go ahead and vote.
Wow.
Looks like their number did. Let's broadcast the results. I don't know if you can see the results, but it looks like 76% did not, but about 24% did dip into the virtual CROI. So that's super. Next question. It's not showing on my screen. Please rate your level of experience in medical management of HIV infection. Any that have attended our courses have seen this question before. Do you consider yourself just starting, a novice, or an old hand, or maybe not so old, but an expert hand at this? So go ahead and vote. Okay, it looks like most people have voted. So what we see then is that a very few novices. We do need some more people in the field, but a good distribution with kind of the bulk of people in the level 3 or level 4, but a few people, 18%, showing real expertise. Okay, I think it's my time now to turn this to Jerry to continue the welcome and start the program. Jerry?
Okay. Good afternoon, everybody. Am I on? Can you hear me?
Yes.
Yes, I can hear you.
Okay, wonderful. So thank you all in New York and in Atlanta for attending this unique event in the midst of the unique events that we're going to be talking about in our history as clinicians and people working for, many of you, it looks like, so experienced for decades in the HIV/AIDS epidemic. This is so unusual in that now we're in the context of a second epidemic in the middle of the continuing HIV epidemic. And I've always thought that the people who are on this, who are attending this this course are really the heroes and the heroines, unsung in the HIV epidemic. We see a lot of press, we hear a lot in the media, but you all are the ones on the front lines. And hopefully this will be helpful for you to continue the really wonderful work, committed work that you've been doing. But now you're on the front lines of 2 epidemics, and how extraordinarily difficult that must be and will continue to be. So whoops, we're all at home. So my congratulations to all of you for the work that you do, and great, I think, admiration. So it's my pleasure to introduce the first speaker, Joe Eron. Joe is one of those long-term, enormously wonderful contributors to knowledge in the HIV/AIDS epidemic and to the practice and treatment of people living with HIV. He's professor of medicine and epidemiology at the University of North Carolina in Chapel Hill. So Joe is going to be talking in 2 places during this course. Initially now discussing new issues related to cure. And it is remarkable that we're talking about cure of HIV, and we're now dealing with a new epidemic in which we're going to go through some of the same processes of trying to learn about that. Joe will be speaking about cure, and then we'll speak after that in a second chapter on issues related to antiretroviral therapy, both treatment and intervention. So Joe, over to you.
Great. Well, welcome everybody. I'm amazed that people have time to take out of their day to listen to us speak. I hope that what I talk to you about will be informative, and again, it's my pleasure to be with you, and thanks, Jerry, for that really nice introduction. I'm going to touch on really highlights, and I urge everyone to use the chat box to ask questions if you have them. In the realm of cure, these are my financial relationships, so you can see them. So in the realm of cure studies, there were a few clinical studies that I think are worth mentioning. The first was this study of vesitolamod. Now that's a TLR7 agonist. What that drug does is it stimulates the immune system at a very basic level, including interferon and NK cell activation. And in several animal studies, predominantly monkey studies, it appeared to be a latency reversing agent. So this study looked at individuals who were HIV positive, previously known to be controllers, meaning they had a low viral load, less than 10,000, who were then placed on therapy. And what happened in this study is those people were then randomized to receive either a placebo or vesitolamide, or the tolamode, the TLR7 agonist. The thought was that this medication might actually stimulate a further immune response and perhaps also stimulate virus production, so immune clearance mechanisms would then lower the reservoir. It was a small study, 15 people on vesitolamide and 8 on placebo, 2-to-1 randomization. And what you can see on the left is it may have had a small effect on viral rebound. And what you can see on the right, it may have lowered the viral load set point, which was available from these participants prior to starting antiretroviral therapy. Though if you did a comparison between arms, there would have been no significant difference. So this is a beginning. Maybe the most important part of this study was that actually vesitolamod was well tolerated in people with HIV, and I'm sure we'll hear more about whether there was any stimulation of HIV activation, and there are additional studies with this medication planned. There were a couple other studies in humans. The one by Dr. Casaza was really, I think, kind of a remarkable study. What that group did at the VRC was they took an adeno-associated virus vector, AAV, and they actually, instead of putting in an antigen to stimulate the immune system, they actually put in the genetic material for VRC-07. So they actually immunize someone with the genetic material to make a broadly neutralizing antibody. And they did this in several different cohorts of HIV-positive people suppressed on therapy. And the idea was that perhaps this gene would get incorporated into cells, probably muscle cells, and then produce this antibody, so produce a neutralizing antibody. And I think what was remarkable was they showed data from 5 participants that had actual continued antibody production, so VRC-07, which is a broadly neutralizing antibody production, after over a year following the injection. and they all, unfortunately, 2 of the 5 actually developed an anti-drug antibody, which we haven't seen in other vaccine studies. So that may say something about how this antibody is expressed. But I think this is a potentially very exciting study. These participants remained on antiretroviral therapy the entire time, so we don't know if that antibody would have helped control their virus, and I assume that those studies will be coming. A second human study came from the very active group in Denmark, where they did a randomized trial of romidepsin, which many of you know as a latency reversing agent, with or without another broadly neutralizing antibody called 3-BNC117, which was developed by Michel Nussensweg and many of your colleagues, who is a colleague of many of you in New York. Unfortunately, what they showed is there really was very limited additional activity of the broadly neutralizing antibody to romidepsin. And overall, there was really very little impact on the reservoir in that study, though there was some secondary endpoints that suggested maybe there was some impact, but it really was, I think, overall a negative study, and it may be due to the fact that only a single broadly neutralizing antibody was used. And finally, one of the tests that's being developed, and I think will become more and more important, is something called IPDA. IPDA stands for Intact Proviral DNA assay, and what that basically does is measures HIV DNA, but does it in a way that it only quantifies cells that have a fully intact HIV genome. It's not perfect, but other HIV DNA assays that you may have heard about measure both fully intact genomes and partial genomes, and maybe as much as 95% really junk. This assay is much more quantitative in terms of viruses in cells that are likely to be replication competent. Again, it's not perfect, but it's much better. These are data from Raj Gandhi and the ACDG showing that over time in people who are suppressed, so there's no intervention here, it's just people are suppressed, and it shows that over time, on average, this IPDA does decrease. Now, it decreases slowly. These are people who've been suppressed for a very long time, but it does suggest that it is measuring something that's in a dynamic and that it is slowly being cleared. With the same assay, you can actually look at essentially pieces of DNA junk at the far ends of the DNA genome, and Raj and his colleagues were actually able to show that those the measures of the kind of junk DNA, junk HIV DNA, actually didn't change at all over the same time period. So this is, I think you'll be hearing more about this IPDA assay as we go forward. Then there were 2 animal studies, and these are studies in rhesus macaques, and I'm quite convinced that you can do a lot of things to rhesus macaques that you can't do to humans, and that rhesus macaques probably respond better to interventions than humans will, but we don't know that for sure. These are data from Dan Baruch, and I'll just make this short. Basically, he took rhesus macaques, started them on treatment 9 days after infection. So remember that these are macaques that are started earlier than we could ever possibly start a person. So it's not 9 days after virus is detected, but 9 days after infection. They're suppressed for a long period, almost, a year and a half, basically. And then they had one of 3 interventions. They either got a broadly neutralizing antibody plus this vesitolamide that I mentioned, the TLR7 agonist. They got a vaccine plus vesitolamide, which is the bottom left. Oh, I can point. If someone could give me that arrow, that would be like super. And then the fourth group, which is down on the bottom right, actually got, oh, there it is. Beautiful. Here it comes. Down in the bottom right here, actually got the vaccine, the broadly neutralizing antibody, and vesitolamide, which I mentioned is probably a latency reversing agent and an immune stimulant. And the bottom line is the monkeys that got all three interventions, many of them rebounded, but 6 out of 10 actually controlled. And here's the control group over here that got no intervention. You can see that they all rebounded and none of them controlled. So this is something which we're getting close to be able to doing. We have these antibodies. We have a similar vaccine to this one. And as I mentioned already, we have vesitolamide. So maybe this is something that can be done in humans in the near future. And then in a similar study, James Whitney, who's in Boston, took also macaques, and remember you can do a lot of stuff to macaques that you can't do to humans. He took a different activating agent. This is N803. It's called an IL-15 superagonist. It's also kind of both stimulates latently infected virus, but also activates immunity. And then these animals were treated after 51 days after infection, so this is something that's obviously a little bit more doable in people. They were suppressed again for a long time, about a year and a half, a little bit less. And then they got N803 plus IL-15 or just a control group. And what you can see is the vast majority of these animals also controlled. Not all of them, but the vast majority of these animals also controlled. Whereas most of the other animals didn't control, though there looks like there's one that's potentially controlling at least slightly. So I think that there's evidence that perhaps by manipulating the immune system and using these broadly neutralizing antibodies, we might be able to induce control. And Tim Wilkin, who many of you know at Cornell, actually has a study really almost identical to this that the ACDG is planning, which unfortunately because of COVID is now temporarily on hold. And then finally, I just want to remind you of the case studies of cure. I think we can probably argue that we have maybe 3.5 and now perhaps 4 people that are cured. The first one is the London patient, which you heard about last year. His case was presented again by Dr. Gupta. He's now 2.5 years after stopping ART. As best they can measure, all of his cells are from the donor. All of his blood cells are from the donor. And they presented data from blood, colonic biopsies, like all over the colon, semen and CSF that were HIV negative. They did that IPDA assay that I mentioned. That was negative. They did find some partial DNA transcripts in the lymph node that they biopsied. These are the pieces of junk that I mentioned. This does not surprise me at all that they might have found some of these in the lymph node, and he remains off therapy. And I think he's likely to be cured, though again, we only know over time. Then this is what people have called the Dusseldorf patient, really very similar to Timothy Ray Brown and the London patient. They presented data from 14 months post-ART interruption. They also only found traces of HIV in the gut and the lymph node, found no replication-competent HIV and no HIV in the blood. And they also showed that the antibody response was almost gone in this person, suggesting that there was no antigen being expressed, at least not a level that would induce antibody not immunity, but antibody reaction. And finally, there was I don't know where this child is from. I think they're from Texas. So this is a Mississippi baby part 2. This was a young boy, I believe, who started ART 33 hours after he was born. and continued for a year. Then his therapy was stopped by his mother. And data were presented that he's now 3 years post-ART. His HIV RNA is less than 20, and there were only traces of HIV DNA in the blood, and with no virus recovery with various assays that look at actual viral replication. And he also has this waning antibody response. In fact, many of his antibodies to HIV-specific proteins were gone. So this is a very quick summary on cure. There was some tremendous pathogenesis work on the more basic level about HIV replication. And then I'm going to come back in a little while to talk to you about HIV treatment.
Wonderful. Do we have Dr. Lennox on the line?
Yes, we do.
Wonderful.
And it's,
Then
I'm
turning
going
it
to go
over
ahead and, okay, thank you. Good afternoon, everybody. I'm glad to hear that we've got a nice sample of audience from both Atlanta and New York. I'm Jeff Lennox. I'm one of the co-directors, along with the person I'm about to introduce, of the Atlanta course. And that co-director is Dr. Michael Saag, who is a well-known HIV/AIDS researcher. He's the Jim Staley Professor in the Division of Infectious Diseases at UAB, Director of the UAB Center for AIDS Research, and Associate Dean for Global Health. And he's an internationally renowned HIV researcher and is going to be talking with us today about his recent experience and ongoing recovery from coronavirus infection. And I'll turn it over to you, Mike. Thank you for being here and for telling your story today.
Thank you, Jeff. Thanks, everybody. Hello. Greetings from some locked away room in my house in Birmingham. I usually bring cases from the clinic. This one is first person. I've used my age before to introduce a case, but not the actual story. So just thought it would be worthwhile to hear what it's like to pick this up and the sort of horror of the roller coaster that this infection at least has been for me, with an eye towards helping us all understand what patients might be going through when you take care of them in the hospital or hopefully more at home. So my story starts at the end of the virtual CROI. My son lives in New York, wanted me to come by and drive with him from New York back to Birmingham because his dog wanted to get back to Birmingham for a little while. So I took the train from Boston to New York. We rented a car, and this was Thursday right after CROI. And that night we stayed over in a hotel. And by that time, Harry, my son, wasn't feeling real well. It wasn't clear what was wrong. And the whole next day we made it back to Birmingham. By the time we got here, he started having a chill, and he had up to 102 fever. So we looked at each other and said, okay, I think you've got this. So we quarantined ourselves in different parts of the house. Saturday, this is now the 14th of March, I started developing some symptoms, and I think there's a couple of key points. Unlike the flu, this is not a sudden onset. The flu comes on, boom, you're suddenly sick. You don't feel good. You've got myalgias. You just feel like you got hit by a truck. In this case, for me, it started off with a little bit of a runny nose, a headache, a nagging cough, but it wasn't terrible, and some malaise. It also had associated with it something I don't know a medical term for, but just I couldn't think straight. I was had inability to concentrate, and even just doing emails would make me have a headache, so I couldn't do a lot of focused work. The next day, more or less progression of the same, but not terrible. One thing that I have noticed that was subtle is I started losing my sense of smell, and up to 40% of cases, maybe more than that, lose their sense of smell during the process of this. Harry and I were both able to get tested on that Monday, and we got our test results back on Tuesday. I remember the person at the lab sent me an email and said, your test was positive, I'm so sorry. And I thought, okay, it's all right. I don't feel that bad. And about Tuesday afternoon, evening, I was maybe starting to feel a little better. Harry was certainly better by then. And by Wednesday morning, I felt almost normal. And I thought, all right, this thing's not so bad. It's a mild case. I'm over it. And I was ready to move on. So that Wednesday, I was able to focus a little more, and I did some work. Wednesday night, all hell broke loose. And I could tell that it was, lack of a better word, a cytokine storm. Shaking, chill, low-grade fever, not high, 100.5, 101 max. But just wasn't right. That fuzzy thinking, feeling like I was in a fog all the time. Lost a lot of my appetite. Again, the taste wasn't there. And just trying to hope that this would go away. And knowing what I knew about how this virus progresses, I went out and got a pulse oximeter, and the thing I monitored like a hawk was my pulse oxes and any degree of dyspnea. By mid-afternoon on Thursday, I really wasn't getting any better, and I became concerned that I was starting perhaps to go in the wrong direction. Didn't feel like I needed to go to the hospital, but by then the data had just come out of France about Plaquenil and Azithro. So several colleagues said, "Yo, you should try this." And I figured, well, I don't know that it's going to be an antiviral, but I'll at least take the Plaquenil in case it has some anti-inflammatory response, because I sure don't want to go through those spells of the cytokine storm again. So I started that, and to be honest, I can't tell that over the 5 days after that, I can't tell that it really did anything. I guess if I'd measured viral load every day, maybe it was having some effect. But for the next 5 days, it was just like copy-paste. The mornings were fine. Woke up without fever. Then by 4 in the afternoon, started having a chill sensation. By 6 o'clock at night, the full bore of cytokine storm. And then each night was just like, imagine your worst night on call, for those of you who remember taking all-night call in the hospital. And, you're getting clobbered, and you just kind of think to yourself, there's got to be a morning after if I can just survive this night. And that's what it was like. I would just sit 2 in the morning, 3 in the morning, trying to get to sleep, couldn't really fall asleep because it just was so uncomfortable. It wasn't pain per se, just a total feeling of dysphoria and just wanting to get whatever this was over. The mornings, again, were okay. I was able to, get up and move around, fortunately no shortness of breath. And that continued over the course of the next 5 or 6 days. And that almost takes us to where we are. On Tuesday night, I think, was my last bad night. Wednesday night, which was last night, I finally had a decent night. And I think it's just running its course. I'm now at about day 13. And I think there are several take-home points from this. The first is this virus is very contagious. Harry and I were very careful, even though I didn't suspect he had it until we were driving on Friday. But we were doing all the right things in terms of, just elbow bumps and wiping things down in the car. But despite that, I became infected. The second thing is the course is very unpredictable. And for me, it was biphasic, just the initial symptoms that seemed to get better, and then the cytokine storm activity, which is horrible. And I think you talk to any patient who's gone through it, they just want it to be over. And I think I'm fortunately at that point where I may be turning the corner. I think I am. But that day can't come soon enough. The third thing is that people are going to be desperate for treatment. I'm certainly not going to advocate taking Plaquenil and Azithro. For one thing, I don't know that it really worked. There's a study that came out yesterday that showed in a controlled trial it didn't seem to have an effect, but that wasn't a great study either. The one out of France was 22 people. This study was 30, but the recent study was at least randomized and controlled. But still, I don't think it's a panacea, the Plaquenil and Azithro. We definitely need studies. I know the ACTG is about ready to embark on one, we should be putting patients into the studies if we can. And then the fourth thing is just monitoring people for deterioration. For folks that are my age, I'm 64, for folks that are in the age group over 60, there's any moment where things could go south. And they can go south pretty quickly. You hear stories of people in the hospital who are being monitored and their oxygenation and whatnot are okay, and then suddenly they start frothing and coughing up pinkish sputa that's foamy, and they require intubation pretty quickly. I had that in my back of my mind every day that I wasn't feeling well, and was just watching like a hawk every breath I took almost to make sure I wasn't heading in a bad direction. And again, fortunately, I didn't experience that. But it is something that nobody wants to go through. You should, obviously everybody's taking precautions, but for those people who are ignoring the shelter-at-home rules, I think they're foolish. This is a terrible thing to get, not only for the individual, but for their family, and also for our community. If we're going to get through this, all of us have got to be responsible and take on this shelter at home. If we are, like all of us are healthcare workers, we're going to have to do what we have to do to take care of our patients. But it still is it's a very difficult thing to experience, partly because of what's unknown with each individual illness, and partly because of what's known, that we know that this can go south in a hurry. I think that's about it. I wouldn't wish this on anybody, friend or foe. It is something that nobody bargains for, and I'm glad that I'm through the worst of it. At least I think I am. Not that I'm glad, I think I'm through the worst of it. And I appreciate the opportunity to share my experience with you, and I'm happy to take questions later. The picture you're seeing there is me hunkered down in my, what I call my Rikers Island cell inside our house. That's where I spend 23 3/4 of an hour every day. Believe it or not, I think because I was sick and didn't feel good, it didn't bother me to be locked up like that. Today's the first day I'm getting a little bit of antsiness being in a room, so maybe that's a sign I'm getting better. Well, thanks again for the opportunity. I'll turn it back over to Dr. Eron to finish out the antiretroviral therapy portion.
Great, thanks, Mike. That was really terrific, and thank you for being willing to talk to us so openly. I got a feeling that most of the questions are going to be to you, so you probably should get ready to answer a bunch. So I'm going to talk about antiretroviral drugs and strategies. This is obviously a highlight of some of the larger studies and the comparative studies and studies that have been done addressing new strategies. So if I missed your favorite study, potentially I could answer your questions. So if you have them, feel free to ask them. So I'm going to talk about the long-acting therapy that's in phase 3 study right now, which is cabotegravir and rilpivirine. I'm going to speak a little bit about switch strategies and clinical studies that support them, and then novel agents, and then at the very end there's a bit of a hodgepodge of stuff that I think you'll find interesting, at least I hope. So in terms of long-acting therapy, probably the most important study there that will affect our care of patients as soon as the drugs are approved was presented by Turner, Overton, and it was the ATLAS-2M study. This is a little bit complicated, but basically ATLAS-2M compared long-acting cabotegravir and rilpivirine dosed every 8 weeks compared to the same drugs dosed every 4 weeks. And there was just over 500 people in each arm. People got into the study in slightly different ways. Some came from the ATLAS study, which was a comparison of every 4-week cab rilpivirine compared to oral standard of care, and those people, whether they were already on rilpivirine or oral standard of care, were then randomized. And then people who were out in the wild and not on a study, but on an anchor agent and 2 NRTIs were also allowed to enter. And you can see the distribution. About almost 400 people came from every 4-week therapy, and then 650 or so came from an oral therapy, whether it was from Atlas on the control arm or out in the wild. And then what we're going to see are the 48-week results of this comparison that was, excuse me, it was an open label study, so that's important. There were no sham injections monthly in the control group. So the results are here. They're very straightforward and I think easy to interpret. If someone could give me my, I got my arrow back. So good. So this is the every 8 week. This is the every 4 week. You can see virologic success was really common and excellent. Virologic non-response, which is greater than 50 at 48 weeks, was a little bit more common in the Q8 week arm, and then no viral, essentially failure or no data. So this is no virologic data. I'm sorry I cut this off. Was a little bit more common in the every 4-week group, which maybe you would have predicted. And then if you look at the non-inferiority margin, obviously the every 8 week was non-inferior, even with this tight 4% non-inferiority margin. And if we look at the proportion suppressed, which is a secondary outcome, you can see they were obviously virtually identical and well within the non-inferiority margin. So that looks great. And maybe every 8 weeks is going to be where we move to. Obviously, it's 6 injections a year instead of 12, so that's obviously a substantial advantage. It is a larger volume of injection, so it's 3 cc's IM, 3 cc injections. If we look at the kind of virologic outcome, so there were 9 participants that had a viral load greater than 50 versus 5, 8 weeks versus 4 weeks, and then the no virologic data, again, a little bit different. There was a little bit more discontinuation, either due to AEs or due to other reasons in the every 4-week arm. But like everything in life, there's a trade-off. And here's the trade-off. The trade-off is that there were a few more confirmed virologic failures, 8 versus 2. Now, 8, that's a small number. It's less than 2%, obviously. But 6 of the 8 had rilpivirine resistance mutations that were selected, and 5 of the 8 had integrase resistance mutations that were selected, including the Q148R, which is a broadly cross-resistant type mutation, and the N155H, a mutation that we've normally associated with raltegravir. Every 4 was excellent. There was only 2 virologic failures, 1 with resistance, and those patients, those participants, that came from the previous Atlas study already on every 4-week therapy, nobody failed in either arm in that group. And I'll give you more information. There was an evidence of some baseline resistance by PBMC DNA in the Q8 week arm. So maybe there was some seeding of rilpivirine resistance. You can see here are some of the mutations that were present in 5 of the 8 people. There really wasn't any seeding of integrase resistance, with maybe 1 exception. And in this case, they weren't all genotype A1 or A6. There was a spread. So I think it was maybe the resistance story is going to expand a little bit. The good news is 9 of these 10 people resuppressed on oral therapy. And phenotypically, they remain sensitive to dolutegravir. I don't know exactly which oral therapy they went on, but I've been told that we will learn that. And so, again, I think every 8 weeks looked very good, but there may be a trade-off in resistance versus success. Though, again, the percentage with resistance was quite small, though developing integrase resistance is not an insignificant issue. And what you might expect, I think, is that there were fewer injection site reactions in the every 8 weeks because they got fewer injections. And like our other studies that we've seen, most of them were grade 1 and grade 2, and they take about 3 days to resolve. We also saw the FLARE study. So FLARE, you'll recall, were people that were previously treatment naive. They went on to oral therapy over about 20 weeks, and if they were suppressed, they were randomized to go on dolutegravir, abacavir, 3TC, or go on to injectable. And this is 96-week data. We saw 48-week data previously, and that's actually been published in the New England Journal. People can look at that, the 48-week data. And what you can see is the 96-week data looks very, very good, very, very similar, though slightly lower in the folks that were on the injectable. That's the green. You can see there was absolutely no difference in virologic non-response, a slight difference in no virologic data. I think here, no individual who was suppressed at week 48 that continued on their injectable therapy had confirmed virologic failure. So I think it's telling us if you are suppressed on this long-acting therapy, the likelihood that you'll sustain your suppression is actually quite good. Not surprisingly, the proportion of patients that had injection site reactions at each visit declined over time. After week 60, only about 20% of people had a injection site reaction, and like all the previous studies, most of these reactions were grade 1 and grade 2, and on average lasted about 3 days. Here's the flip side. So these are a small amount of data. I think this is from 34 people who were either on Latte-2, which was a long-acting injectable, or Atlas, which again was a long-acting injectable study of both these drugs. Latte-2 and Atlas were every 4 weeks at least initially, though Latte-2 was both 4 and 8. And this is looking at people who stopped, and then looking at the decline in cabotegravir here on the left and rilpivirine here on the right. And this bottom line, this is not days or hours or weeks, this is months. And what you can see is these drugs last a long time, and they're not quite parallel, right? Rilpivirine seems to have an exceedingly long half-life with values above the limit of above the therapeutic, presumably therapeutic minimum out to a year. So obviously people who stop long-acting injectable therapy, our goal would be to get them on oral therapy. But if they have trouble with oral therapy, they're going to have some drug around for a substantial period of time. Okay, what about switch strategies? I'm going to go a little bit quicker through some of these switch strategies. One of the topics that's come up in the switch strategy, there you go, is what about archive resistance? How important is that when we switch someone to a treatment, especially a treatment that contains 2 drugs? So I think people are very familiar with the TANGO study. The TANGO study was a randomized study of people suppressed on a 3-drug TAF-based therapy. They're randomized to continue on TAF versus switch to dolutegravir 3TC. People will recall that over time, at 48 weeks, there was an excellent response across both arms with almost no virologic failure in either arm, which is terrific. But what about baseline archived resistance? So the organizers of this study went back and did archived DNA on all all participants in both arms. About over 2/3, about 75% of those assays were successful. So you ended up with 320 or so in both groups having data on their baseline resistance. So remember, you could have no history of virologic failure to get into this study, and 75% or so had no major RAMs in their archived DNA. But you can see that there were NRTI RAMs, though 184V was uncommon, 4 and 3. There were NNRTI RAMs, which isn't surprising because that's a transmitted resistance mutation in 12%. There were occasionally PI protease inhibitor RAMs, and again, these are probably transmitted protease mutations, 146 and D30N. And then there were a small number of integrase resistance mutations in this archived DNA. So as you might expect, this had absolutely no impact on outcome. Blue at top is 2-drug, bottom is 3-drug. Blue is overall, whatever color that is, orange or red, depending on your eyesight, is any major class resistance. And then green is no resistance. Brown is NRTI, and purple, I guess that is, was integrase. And basically, there's no difference. And there was very, very few virologic non-responses. There was one essentially here, which was someone who stopped the study early. This is 2-drug, remember. This is 3-drug. There's really no difference. So in people that haven't had previous virologic failure, this concern about archive resistance, I think, is not a major concern in switch. Here's a much smaller study, but where they actually looked at people who had known 3TC resistance archived, and then compared them to a similar number of patients who didn't have any archive resistance. And the bottom line is that there was no virologic failure in either subset. Remember, 21 versus 20, so it's a small study, but no virologic failure. There was one discontinuation for an adverse event, and 2 people that stopped therapy, one here, but their viral load was less than 50. So again, this concern about archive resistance, I think, is somewhat less. Then one group where we don't have as much data as we'd like with some of our novel second-generation protease inhibitors. This is a study of bictegravir TAF FTC in African Americans. This is called the BRAVE study with 2 A's for African American. This was presented by Dr. Higgins from, I'm going to mix up whether she's from Georgia or South Carolina. And this was a straightforward switch study, a 2-to-1 randomization. People were self-described as African American or black. They had to be suppressed on therapy. They had to have a ECRF, ECRF. God, you can tell I'm a clinical investigator. A EGFR of greater than 50, and they had to be on this regimen for 6 months. They just couldn't have resistance to integrase inhibitors in their past, and they're randomized to switch to BF-TAF versus staying on their regimen for 24 weeks and then switching 24 weeks as the primary endpoint. You can see they were excluded if they had a history. If they had a history of tenofovir resistance or a whole bunch of TAMs, or if they had integrase resistance. But a lot of other people were included, even if they had a 184V, for example. And what you can see on this next slide is they did very, very, very well. Again, BF-TAF is on the lighter, pretty green color, and the continued is in the darker gray. And I'm not going to go into more detail. Obviously, they did fine. Archive resistance didn't really make any difference in this study either. And if you take people who are suppressed, they really typically stay suppressed. And we have many, 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 many studies that have shown that. And this is another one where individuals were on sustained suppression, no virologic history of virologic failure. They had to be on essentially a first or second regimen with no history of virologic failure. They switched to dolutegravir rilpivirine versus continue on their current therapy for a year, and then everyone went to dolutegravir rilpivirine. And I'm just going to show you two quick things. What this is the darker color on either side is target not detected, and then this fuzzy part on the top is below quantifiable but target detected, and this is comparing 2-drug, which in the dark here, versus continued 3-drug in the dark green. And then obviously everybody here is on 2 drugs, though the orange are the late switchers and the dark blue are the early switchers. And basically there's absolutely no difference between the two. And then if we look at the kind of low-level virologic rebound in these people, again, I think it's pretty clear that this very low-level rebound between 40 and 50, which is, boy, that's like a razor-thin level. You can see there's really no difference except perhaps at this one point, and I'm not sure what was going on there. If you look at less than 200, greater than 50, no difference. And then if you look at viral loads greater than 200, again, you see no difference. And so once again, 2-drug therapy works, especially if you cohort it to people who have not had previous virologic failure. And then this is a real-world study. This is from the opera group. I don't particularly like the term real-world, since I think we all live in the real world. Well, at least most of us, maybe not Mike, Saag. This looked at 500 individuals in this large collaborative cohort versus 5,000, 2-drug versus 3-drug, again, switch therapy. This is time to virologic failure, and it was obviously super uncommon and absolutely no different. Okay. What about novel agents? Well, I will say there was not a lot of data on novel agents at CROI, but there was some exciting data, I think, about 2 of them. This is data on the capsid inhibitor. This is GS6207, and these are data that actually were presented previously, but Eric Dar showed them again. This is giving people a single injection of 20, 50, 150, 450, or 750 milligrams of this capsid inhibitor, and looking at virologic response over 10 days. And you can see at the higher doses, you really get this peak decline of over 2 logs, which is, I think, about what you can do in 10 days with kind of full virologic suppression, which, Mike Saag was one of the people that showed this quite some time ago, looking at viral dynamics. The capsid inhibitor, capsid is now really interesting. There was some terrific science on capsid, which those of you who are kind of science geeks, you might want to go listen to those presentations. It turns out capsid is really important not only in the virus entering the cell, it's incredibly important in reverse transcription, and as it turns out, it's probably important in actually moving the viral DNA, the HIV DNA, into the nucleus. And actually, some capsid actually appears to get into the nucleus. So this is a really important part of HIV replication. So blocking capsid is likely to be very potent. You can see that it is. But one issue is it's really hard to start someone out with an injection. And you might say, well, what if we want to give people oral therapy first? So the study that Eric did actually looked at oral therapy, and I'm gonna go back and correct myself on the previous slide. So they looked at the dose response. I'm gonna keep myself from getting mixed up. So in the IV therapy, they looked at the dose response. This is an Emax curve. So anybody that remembers any pharmacology, Emax is trying to come up with the concentration. This is a Cmin type concentration that's associated with full suppression. And you can see that it's somewhere between 4.4 nanograms per ml and this is 13 nanograms per ml. It's probably in this range somewhere. You don't gain much more with increasing concentrations. And this is all modeled from the injection study. So what Eric showed is PK of oral therapy. So this is just PK. This is not antiviral activity, but this is PK of oral therapy. A year ago, people were saying, well, there won't be any oral form of this capsid inhibitor. Well, that turned out to be wrong. There is an oral form of this capsid inhibitor. And what you can see is a single oral dose, 50, 300, 900, or 1,800 milligrams, produces measurable levels for actually quite a long period of time, out to over a month, depending on the amount of the dose. This dotted line I put in there, that's right around 4.4. And what you can see, I think, basically is that maybe not with 50, but with 300 and onward and upward, you maintain a level above this 4.4 for at least 2 weeks and maybe a little bit longer. So oral therapy looks feasible with the capsid inhibitor. And I think the studies that are in phase 2 and phase 3 have an oral component of this capsid inhibitor. And obviously those are exciting studies that unfortunately, again, are also not moving forward with additional randomizations during this COVID period. And then islatravir, people probably know islatravir is it's a nucleoside, but it's an NRTTI because it not only does it block reverse transcription, which is going on over here, it also blocks translation. It keeps the RNA, the reverse transcriptase from sliding down the RNA template. So it's extremely potent. And there were 2 studies presented, and these studies involved an IV challenge and then post-exposure prophylaxis. You might remember that Marty Markowitz showed that pre-exposure prophylaxis was effective in this monkey model. Well, this was a monkey model of post-exposure prophylaxis with a single drug, and they did it 2 ways. They did. They started 48 hours after an IV challenge, so this is a serious challenge of very pathogenic SIV virus in monkeys. And they either did multiple doses of weekly islatravir, 2, 3, or 4 doses, or a single dose of islatravir 24 hours post-challenge. And what you can see is that if they gave multiple doses, 4, 3, or 2 weekly doses, all the controls got infected, obviously with an IV challenge with a very high viral load, but all the animals, 2 animals got 4, 2 animals got 3, 2 animals got 2 weekly doses. They were all protected, and there's continued follow-up. And then the animals that got just a single dose, there was a rebound in 2 out of the 4, but 4 out of the 6 maintained protection in this post-exposure prophylaxis model. So interesting. and something to think about for the future. You could imagine either healthcare-associated exposure or non-healthcare-associated exposure perhaps could be treated with a couple of injections as opposed to pills for a month. So something to think about for the future. Okay, so just to have a couple more comments, and I'll be done, and we'll have time for questions. This is from the Gemini study. Remember, Gemini was a treatment-naive study comparing dolutegravir 3-TC versus dolutegravir TDF-FTC. About 700 people in each arm. This was presented by Mark Underwood. And this is just looking at confirmed virologic withdrawals through 96 weeks. So this is just looking at all the patients that had a virologic rebound above 200 copies that were confirmed. And you can see there were 11 in the 2-drug arm. Let me get my pointer again, get it back. Here it is. 11 in the 2-drug arm, 7 in the 3-drug arm. So that's a little over 1% and almost exactly 1%. And you can see these people do rebound. Many of them are actually going back down again, even though they haven't yet changed therapy. Now, they were required to come off therapy if they had 2 values confirmed above 200. You can see this also happened on the 3-drug side over here. And probably the major message is that none of these 18 individuals had treatment-emergent resistance. So there are rebounds. They do occur. I think the implication is that if you see them going back down again, that it's probably people who stopped therapy and then restarted again once somebody said, hey, your viral load's going up. I think that's validated in part by the fact that they did not, nobody developed resistance as yet in the Gemini study. Just a couple more things. This is looking at trends in resistance. This is from a large company in California that does lots of resistance testing. This is over the last, from 2012 to 2018. They looked at 84,000 samples, and they decided to look at the samples that had some resistance. So you guys can probably do the math faster than me, but I think it's like 57,000 samples or so didn't have any resistance. 27,000, almost 28,000 did. And what they saw is, I bet most of you would have predicted this. In those people who had resistance, about 75% had NNRTI resistance, not surprising. About 50%, a little bit less by 2018, had nuke resistance. A low percentage, 8%, had PI resistance, and 17% had integrase resistance. And though I don't know the data in any more detail than this, I suspect that a substantial number of these might be resistant to our first-generation integrase inhibitors, and maybe even that 97A mutation that can also be a polymorphism. On the other hand, if you look at multiple class resistance, you can see it rapidly becomes uncommon. This is 2-class resistance here, 20%. And remember, this is just of people that have resistance. So 70% of the people that have resistance only have it to a single class. 22% have it to 2 classes. 5% have it to 3 classes. And 1% have it to 4 classes. So that's obviously quite uncommon, but not zero. So we probably will need some of these other new drugs that are being developed for people with extensive drug resistance. 2 more things and then I'm done. We've all heard about the life expectancy being narrowed in people with HIV. So this is a model from the Kaiser database by Julia Marcus. 39,000 HIV positive people, 387,000 HIV negative people, and this is a model saying if you're 21 years old when you start your therapy, how many years do you have to live? And You can see we continue to catch up over time, 65 versus 56 years, additional years. So again, that's 77 years old versus whatever that is, 86 years old. But what Julia did, which is really smart, is she looked at comorbidity-free survival. And that's a little different. If you're HIV positive, your comorbidity-free survival at age 21 is 15 years. So that means you have a comorbidity on average when you're 36 compared to the rest of the world, uninfected people, not the rest of the world, sorry, where they don't experience their first comorbidity on average until they're 52. So this is a really nice study, worth really looking at carefully. And then finally, we saw the 96-week data from Discover. I think people know that Discover was high-risk men who had sex with men with a small percentage of transgender women who were randomized to get FTC-TAF versus FTC-TAF versus FTC-TDF over a 96-week period. And basically, in the period from 48 to 96 weeks, there was only one additional infection in the TAF group, no additional infections in the FTDF group, and the TAF, F-TAF remained non-inferior, though the margin got, the confidence interval got a little bit wider because there was one more infection, and there were no meaningful differences in AEs, drug-related AEs or SAE. So virtual COI, first of all, it was amazing that Donna Jacobson and her crew were able to put this on. It was a really quite an experience to be there and try to do this. We saw some exciting remission data in a non-human primate model. Hopefully we can find that humans are similar to non-human primates. We'll see. Perhaps the number of patients cured is now 4. I think we probably should watch that young child, the 4-year-old child, carefully over time. I think we've seen that long-acting therapy is quite durable, and I think a lot of us will be thinking about giving it every 8 weeks. Some of us might give it every 4 weeks for a while to make sure it's really working and then go to every 8 weeks. That's certainly, you don't have to do it that way when it's approved, but we won't know yet. And there's some really interesting novel therapies coming, the capsid inhibitor and the NRTTI islatravir. So thank you very much. I really appreciate your time.
Thanks. Thanks very much, Joe. The structure now, Jerry and I will be watching the presenter notes that we see, so we can see the questions that the audience is putting forward. We have about not quite 15 minutes left, and want to leave a little bit of time at the end for again for Jerry to wrap up and again kind of put what we're hearing in context of what's going on today. So I guess one of the questions, Jerry, that I see is that as to Mike about his experience with COVID-19, is there an IgM, IgG tests? Are those being deployed? Are you going to be tested? Obviously, we'd all like to know whether there's any kind of longer-term immunity from people like you that have recovered from this.
Yeah, I don't know if that test is available just yet. I will say, I didn't tell you this part, but when I wanted to be tested, I volunteered and sent, both Harry and I both sent cells and serum plasma up to the lab just to be stored. And I'd heard from a number of colleagues at NIH, and I'm going to be donating blood, including cells, as I get to a convalescent phase. The question to ask is really a key one for a couple reasons. One, we don't know how much immunity is there. We're all hopeful that there will be reasonable immunity and that it'll be relatively long-lasting, that would be fantastic. But that, on the other hand, we aren't sure exactly what type of immunity there will be. They're also they're talking about some convalescent serum being used as a therapeutic. Some areas around the country are trying that. So that's something else to look for. And my final point, a number of people, just from the Diamond Princess experience, there were several people who were quarantined after they were removed from the ship, were totally asymptomatic but tested positive, never developed symptoms. And so those folks would be best detected in the general community by having IgM and IgG antibodies. So I suspect there's a portion of our population who have been infected and were entirely asymptomatic. While they were infected, they could well have shed and transmitted the infection to somebody else. I think kids are especially viewed as the type of carriers that might pull that off, because they don't typically get symptoms relative to those who are a little bit older, adolescents and adults. But the bottom line is those types of antibodies will be helpful from an epidemiologic perspective as well as biology in terms of determining immunity.
Hi, this is Jerry. I just wanted to chime in. I think we're going to find, when we actually have the availability of widespread testing and antibody looking, that this virus has been much, much more widely distributed than we think it has. And there's a large pool of asymptomatic individuals who have been infected, who have probably transmitted, and then shed the virus.
Jerry, do you want to toss a question to Joe? Jerry, are you on mute?
How's that?
I can see, Paul. I can see the questions. There's one question about time frame for approval of cavalpivirine. I think everybody knows that the FDA came back to the sponsor with some questions related to the manufacturing process in late December. The company is responding to that. And my understanding is when the response has been submitted, then the FDA will look at it and give a timeline. And usually their timeline is either a month or 3 months, depending on the level of the response. The actual letter that the FDA sent to the company is confidential, so we don't know exactly what was in it. We do know that the company intends to respond. I don't know how, what's happening all over our country with the COVID-19 illness, how that will impact the ability of both the company and the FDA to review this. So I think so it's hard to predict. There's a second question that I'll answer, and then there's some questions from Mike. The question is, what prevented cavalpivirine from being 8 weeks from the start? It was studied 8 weeks and 4 weeks in the Latte-2 study, and somebody had to make a decision. I'm sure a lot of you are making very difficult decisions right now, but at 48 weeks in the Latte-2 study, there was a decision that had to be made whether to go with phase 3 every 8 weeks. And the data was very similar between the two arms, but there were maybe a few more blips on the Q8 at the time of that data review. And I think the conservative hearts won out and went with the every 4 weeks instead of every 8 weeks. Whether they could have gone with every 8 weeks, I think, is an open question, but that's not what happened. But it was studied every 4 and every 8 week in the phase 2B study. And 4 weeks was chosen, I think, to be as safe as possible.
Great. Mike, do you want to take one of the questions there for you?
Sure. One of them was, how easy was it to get tested? And the answer, at least this was a week ago Monday, it wasn't all that easy. I had to contact the lab, a couple of the different labs at UAB directly, and they were doing some final validations, and I convinced them to just run a couple of extra samples while they were finishing their validation runs to add Harry and my sample to it. Nowadays, it's like 10 days later, right? But it's a lot easier to get testing, and that's gone okay. There was one other question here about how confident am I that I actually picked this up from my son. I don't know for sure. The implication from the question is that the so-called 2-week incubation period, that's the high side. The actual estimates are somewhere between 36 hours and 11 days is the range in general. So I was exposed and became sick within 48 hours, which is on the short side of incubation, but it makes the most sense to me. I guess we could always go back and do a genetic analysis of the virus if we wanted to know for sure. But regardless, I think the coincidence was pretty strong that I picked it up during the car ride back from Birmingham to Birmingham.
Mike, a question from me, a personal one. How is your wife doing? Did she get, I guess you don't have to reveal her personal information, but how is she doing?
She's doing well, thanks, Paul. So Harry and I, like I said, we went immediately into quarantine, and we have 2 areas of the house that we call dirty. That's where Harry and I hang out, and then the rest of the house we keep clean. And we try to, we've been very vigilant about when I leave the room, I wash my hands and put on some gloves. I try not to touch anything at all when I go outside the room. Harry's now been well for almost a week, so I think he's no longer infectious or contagious. I think I still may be shedding. I don't know for sure, but I'll continue to observe that sort of isolation for at least a 3 to 4 day period after my symptoms are completely gone.
Great, thanks.
Okay. Here's another question for Dr. Eron. Joe, this is a question about, was there any additional information on at CROI about sequential laser, ART, and CRISPR treatments to eliminate HIV-1 in humanized mice?
Yeah, I can't answer that one. I don't know. As Donna and Mike both know, we were kind of running around making sure everybody's slides were in and trying to host various sessions. So I didn't see that. It's possible.
I don't think it's intended as a criticism.
No, I know. I'm just saying I don't know. I don't feel criticized. I'd like to know the answer, but I don't in this case.
So if it was presented, then it would be available on the. Would it be available on the?
Yes, all the website. All the
it should be on the website. So I would suggest the person who asked the question might actually look through the website and see what the information was.
Yeah, there's a searchable database for abstracts, and then they link over to the posters. And we did end up receiving about more than 90% of the posters. So it's a pretty rich resource for the meeting materials.
Great.
Yeah.
So there's an interesting
I'd like to answer. Is it okay if I answer that one quick question about remdesivir?
I was going to ask. Yeah, go ahead.
Yeah, remdesivir is an RNA polymerase inhibitor. It's not a reverse transcriptase inhibitor. And we don't think that TAF or TDF or any of the nucleoside analogs are RNA polymerase inhibitors. I don't think they've been tested specifically against the SARS-2 virus that's causing COVID-19, but they have been tested against Ebola, against MERS, against the original SARS, and they don't have activity. So remdesivir is a polymerase inhibitor, but it's specifically an RNase polymerase inhibitor.
Right.
Thanks.
So there are a number of studies of remdesivir which are in progress now. I don't know if any sites in New York or Atlanta are participating, but it.
Well, there's several sites up and running now. I mean, we have one at Birmingham. I'm pretty confident there's a couple in Atlanta. They're mostly placebo-controlled for seriously ill folks in the ICU. I don't know of any remdesivir studies for mild illness.
No, right. We're involved in one as well at Yale, and I think that's the quickest way to demonstrate if there is if there's benefit because of the severity of the clinical stage of the illness that they've chosen.
I guess the other question would be, is there any prophylaxis studies going on in healthcare workers?
Yeah, there's Bill and Melinda Gates has one that's starting with the hydroxychloroquine. The PCORI network has one that they're trying to roll out, again with hydroxychloroquine. And there's a smaller one, I think, in Seattle from the University of Washington, all with hydroxychloroquine. I don't know of any other prophylactic study that's ongoing.
Okay, great. Donna, I think we are at the bottom of the hour,
yes.
The bottom half hour.
Yes, let's ask Terry to go through just some of the closing remarks.
Okay. Well, this has been a remarkable event. I want to thank Donna and IAS-USA for pulling it off really flawlessly, I would say. And Joe, for your presentations, they were really amazing and remarkable and beautifully done. And, of course, for Mike being courageous. And, you know, they say that you can learn an enormous amount from a single case. So you don't need necessarily a randomized controlled trial to learn things that you would be unlikely to ever forget. And I think your presentation falls into that category. So thanks for doing it, and thanks for your courage to providing us with that information. And then I wanted to thank the audiences, both in New York and in Atlanta, going back to the original comments, because this is an amazing time in history. We are dealing with two major global epidemics of enormous consequence. One that we've sort of gotten control of, and another that is just